Good day everyone, we are the second group for the Nursing Informatics Laboratory and we are here to report about preeclampsia. But first, let's have an overview. In our presentation, we aim to discuss preeclampsia and some of the information surrounding it in order to provide assistance to those in need. We will also explore potential risk factors, symptoms, and treatment options to help raise awareness and promote early detection. Additionally, we will provide resources for further education and support for individuals affected by this condition. Now, I would like to introduce the group to all of you. Here we have Roderick Barreras, Alliah Licudan, Altea Novincedo, Nico Labsan, and yours truly. We hope we can deliver an effective learning experience to all of you about preeclampsia. Next is our table of contents, wherein you segregate preeclampsia into various topics reported by selected members. So, by now I am sure that in your mind you are thinking about when preeclampsia started and what is preeclampsia. So, let's start. So, Hippocrates, a great physician around 400 BC, was the first to define what would be known in a millennium as preeclampsia, stating that headaches along with heaviness and convulsions during pregnancy were deemed undesirable. So this was the first indication that an unhealthy pregnancy might be connected to a particular entity. Even though this was the first time that the disease was recognized, the only treatment available were to attempt to balance the body fluids using purging and also modified diets. So now let's explore the modern definition of preeclampsia. So, preeclampsia is a pregnancy complication characterized by high blood pressure and signs of damage to other organs, most often known as the liver and kidneys. It usually begins after 20 weeks of pregnancy and can be dangerous if left untreated, potentially leading to serious complications for both the mother and the baby. So now I would like to pass the presentation to the next reporter for a more comprehensive, in-depth review.
So for clinical manifestations, headaches, often described as pounding or throbbing headaches that don't go away with typical remedies. Next is swelling or edema, especially in the hands and face, but can occur in other parts of the body as well. Visual disturbances, such as blurred vision, seeing spots or flashing lights, or temporary loss of vision. Next is shortness of breath. Difficulty breathing occur if fluid accumulates in the lungs due to heart strain from preeclampsia. Nausea or vomiting, especially if it is accompanied by other symptoms like abdominal pain or headache. High blood pressure or hypertension. This is a key feature of preeclampsia. Blood pressure above 140/90 are considered elevated. Proteinuria. Protein in the urine is another hallmark sign of preeclampsia. It indicates kidney damage and is usually detected through urine dipstick test. Upper abdominal pain, especially under the ribs on the right side, which can indicate liver involvement. Decreased urine output. This can indicate kidney impairment. Lastly, gaining weight rapidly, 2 to 5 pounds in a week.
Diagnostics and assessment. First is blood pressure monitoring. Throughout the pregnancy, the blood pressure should be regularly measured. High blood pressure is diagnosed if the systolic pressure is 140 mm of mercury or higher, or if the diastolic pressure is 90 mm of mercury or higher. Second is proteinuria screening. Proteinuria, or the presence of protein in the urine, is a hallmark of preeclampsia. A 24-hour urine collection or a spot urine protein to creatinine ratio can be used for screening. Third is laboratory tests. Blood tests may include complete blood count or CBC to check abnormalities such as low platelet count or hemolysis. Next is liver function test to assess liver function and detect abnormalities. Next is renal function tests, which evaluates the kidney functions, coagulation studies to assess blood clotting function, and fetal ultrasound, which is a non-invasive imaging to monitor the baby's growth and amniotic fluid volume. Fourth is the non-stress test or biophysical profile. In non-stress test, it evaluates the baby's heart rate response to movement. Next is biophysical profile. It uses ultrasound to assess fetal breathing, muscle tone, and amniotic fluid. Fifth is treatment options. Early delivery of the baby may be required if severe preeclampsia occurs. Medications such as antihypertensives, examples are losartan or olmesartan, which manages blood pressure, corticosteroids such as betamethasone to improve liver function, platelet count, and fetal lung maturation, anticonvulsants such as magnesium sulfate, which prevents seizures.
So, I'm Altea Novincedo and I'll be discussing the medical management and pharmacological therapy of preeclampsia during pregnancy. So, in addressing preeclampsia, medical management and pharmacological therapy encompasses various interventions aimed at controlling maternal symptoms, reducing the risk of complication, and promoting favorable outcomes for both mother and baby. So, first is the regular prenatal care. Early detection through check-up is vital, including blood pressure and urine tests to identify preeclampsia. And next is the blood pressure control. Administering medication like labetalol, hydralazine, or nifedipine is crucial to reduce maternal complications such as eclampsia, thus safeguarding maternal health and improving pregnancy outcomes. And of course, the bed rest promotion. So when the body is in a recumbent position, sodium tends to be created at a faster rate than during activity. Bed rest, therefore, is the best method of aiding increased evacuation of sodium and encouraging diuresis. Rest should always be in lateral recumbent position to avoid uterine pressure on the vena cava and prevent supine hypotension syndrome. And of course, the good nutrition promotion. Continuing usual pregnancy nutrition is advised. Strict salt restriction is no longer recommended. And next is the seizure prevention. Prophylactic use of magnesium sulfate prevents eclamptic seizure, minimizing maternal morbidity and mortality. And of course, the fetal lung maturity. Administering corticosteroids, typically betamethasone, is indicated to promote fetal lung maturity in cases of preterm delivery anticipated due to severe preeclampsia. Accelerating fetal lung maturation reduces the risk of respiratory distress syndrome and preterm infants, improving neonatal outcomes and reducing the need for prolonged neonatal intensive care. And last is the delivery. Expedited delivery may be necessary to prevent complications associated with prolonged gestation, either by induction of labor or cesarean section, to optimize outcome for both mother and baby. So that's all for medical management and pharmacological therapy.
Good day everyone, this is Roderick Barreras and I'm going to discuss nursing managements for pregnant women experiencing preeclampsia. First is frequent vital signs checking, especially the blood pressure. Regular blood pressure measurements facilitate the early detection of elevated or worsening levels, thus enabling prompt diagnosis of the condition. Timely identification is essential for initiating appropriate management, which will prevent this preeclampsia to become eclampsia. Second is assessing deep tendon reflexes. Assessing deep tendon reflexes allows healthcare providers to monitor for signs of neurological complications associated with preeclampsia such as eclampsia. Next is assessing fetal heart rate. Continuous assessment of the FHR is crucial for evaluating the well-being of the baby. Preeclampsia can compromise fetal oxygenation and circulation, and monitoring the FHR helps in early detection of potential distress, guiding appropriate obstetric management. Another one is observe for signs of labor in patients with preeclampsia. Preeclampsia can lead to premature labor and delivery. Therefore, close observation for signs of labor such as regular uterine contractions, vaginal bleeding, and rupture of membranes are essential for managing the timing and mode of delivery. We also need to test urine for protein and also input and output monitoring. Testing urine for protein is significant in diagnosing the condition and monitoring its progression. Proteinuria, the presence of protein in urine, is a key diagnostic criterion for preeclampsia. It aids in ruling out or confirming the presence of protein in the urine, indicating kidney impairment, which is a common sign of preeclampsia. Input and output monitoring is also important as it allows for the assessment of the patient's fluid balance and renal function. Detailed recordings of input and output, particularly monitoring fluid balance, are essential to avoid iatrogenic fluid overload, a leading cause of maternal death in preeclampsia. Bed rest or position aside is also important as it can alleviate the pressure on the vena cava and aorta, thus enhancing blood flow to the placenta and enhancing the risk of supine hypotension syndrome. Having oral airway, oxygen, and suction available is important as these are crucial to maintain adequate air exchange, especially in cases where the patient's condition deteriorates, to ensure the patient's airway remains open and unobstructed, safeguarding the respiratory function and overall well-being. For the oxygen, access to this is vital in addressing potential hypoxemia and respiratory compromise, enabling healthcare providers to promptly address any oxygenation issues, ensuring adequate tissue perfusion, and mitigating the risk of maternal and fetal complications associated with hypoxemia. In addition, the availability of suction is important for managing potential airway secretions, preventing airway compromise, and improving overall respiratory function. We also need to decrease environmental stimuli because this is significant in promoting a calm and controlled environment, which can contribute to reducing stress and anxiety levels in these patients. This approach helps in controlling blood pressure, preventing potential triggers for seizures, and supporting the well-being of the patient, thus mitigating the risk of preeclampsia-related complications. We also need magnesium sulfate with close observation because it plays a pivotal role in the management of preeclampsia by preventing seizures and improving pregnancy outcomes. It serves as anticonvulsant of choice for prophylaxis and treatment, effectively preventing progression of preeclampsia to eclampsia. Calcium gluconate at bedside serves as an antidote for magnesium sulfate toxicity. As magnesium sulfate is administered to prevent seizures, careful monitoring is crucial to identify signs of magnesium toxicity. And lastly, implementation of seizure precautions is necessary to nursing management as it prioritizes patient safety, enables early intervention, and supports the overall well-being of individuals at risk of experiencing seizures.